We're going to have a few minutes here of discussion. Dr. Goodney, let me start with you. One of the, and disclosure, we're participating in the BEST CLI trial as well, but I'm going to play devil's advocate, which is variability in treatment. I think most of us will agree that bypass has been around for a long time and the techniques are pretty straightforward or pretty standard in most places. But what about variability in endoluminal treatment? Is that an issue in the trial?
I think it's certainly something that they're going to want to be transparent about. I think you're right that one of the main questions that will surface will be what the relative skill sets will be of the both surgical treatments as well as the endovascular treatment. So I know that's been something that a priori they wanted to make sure they had plenty of data to collect and focus on. My partner, Rick Powell, is the chair of the credentialing committee, so I hear a lot about this around the water cooler in our practice. And in addition to the credentialing process, there's sort of continuing review, if you will, of the endovascular and surgical treatments that are offered. And those of you who participate in the trial know the extent of detail about what's actually done in terms of what's collected and what's recorded. So I think it's a good question, and I think the facts are going to have to speak for themselves. If there are surgical sites that are only offering simple SFA angioplasty, then the evidence sort of offered by this trial may not be sort of taken with the same weight. But at least at our site, I think our ability to provide sort of advanced both endo and open therapy seems to hold up with what's offered nationally on both forums. I'm hopeful that when the trial's published, that will be the case with most, if not all, the sites.
Yeah, I'm just going to interject a little bit. I'm on the committee with Rick, and I think a lot of effort goes into making sure that the operators on both sides are, have considerable amount of experience. And I think everything is done to try to improve that. A PI at a site really is in charge of looking to see if everyone on that site is up to snuff. And I think all the conversations are basically saying, if we don't have equipoise, if both sides aren't equal in terms of that skill level, we're never going to be able to really have a good trial. And I know nothing is perfect, but I think a lot of effort goes into that.
Is the question in the audience?
Yeah, so we are on the BISSE trial also. We started very good in enrolling patients until we started hearing from the endovascular interventionalists only that it is not ethical. So we started losing patients actually because of that. We tried to randomize, like one of the patients that was shown and you presented. I mean, how ethical it is really if you can proceed another 10 minutes and to do the procedure, then stop and randomize. And we had for the last year, because of that, so much difficulty in enrolling patients, although we do interventions about 10 to 12 a week, but we cannot enroll patients because of that. How do you solve this problem?
I'll comment, and then maybe Dr. Pena will as well. I think each individual practice has to adjust a little bit to let their patient flow models allow for that decision making. So one option is on-table randomization, but that's sort of not always so convenient, right? If you've got 6 cases arranged for the day, and now you have to do a complex 3-hour tibial reintervention, you're going to have a bunch of irritated patients in the waiting room, and your recovery room nurses are going to be mad. So it does, we try to identify our potential best candidates very early and sort of arrange their evaluations so that we can do their enrollments beforehand using either CTA imaging or a diagnostic angiogram, and then offer them a expeditious endo or open treatment wherever they get randomized, usually at that same hospitalization. We thought we would enroll patients from the clinic pretty commonly, and actually our best customers, if you will, for best enrollments are those patients who come in the hospital with a foot cellulitis. So if we keep them in the hospital another day to do their endo or open intervention after the diagnostic, it works all right. I don't know, Dr. Pena.
Yeah, I think there's a lot of people that aren't part of the trial because they feel that it should always be endo first. And I'm sure there's some people that say it's surgical first. But the truth is, the reason why we're doing this trial is because we don't have the data, and we need that data. And if people aren't, basically, if they lose that concept of why we're doing the trial, it makes it very difficult. And it sounds like, some of their endovascular people have lost the reason of why we're doing this trial. Because at the end of the day, they say it's unethical, but where's the data where it's unethical? We don't have that data. And we're never going to get that data if you just continue to treat these patients without really having the data, finding out which is better, which of the lesions we treat, it's a very well-powered study. Hopefully we can get a lot of information about which are the right patients for each of the therapies.
I make, and if I may add, I make 2 points to patients. One is that we're going to guarantee we're going to get blood flow to their leg, one way or the other, and they respond to that. And then the second thing I say from a trial standpoint is we all have biases that, I think there's a phenotype of essentially the picture that Dr. Pena showed, usually a small Caucasian woman with small vessels and a small vein that does very poorly with bypass. I have that bias. I have a different bias for older diabetic African American men. And I tell patients, this trial is going to tell us if you're a woman, a man, diabetic, non-diabetic, older, younger, it'll tell us perhaps better targeted therapies that'll help us in the future.
I had a question, a follow-up question related to the similar conversation we have had from Phil and Tino, and that's I was looking at the sites. I noticed that there's a lot of screening, but few patients are randomized. I remember one site had 374 screened patients, but they had randomized only 4. So my question to you is that at the end of the day, I think most likely both modalities are going to be available. I don't think this trial is going to, eliminate one modality. My question to you is that how are we going to change that graph that you showed, Phil, where there are many sites that only do endo and there are those sites that only do surgery? How are we going to change that? How are we going to impact that?
Yeah, I mean that's a great question. I think it's going to take time. My discussion with the patients very closely mirrors Vic's, in that we tell them, look, we're going to get you fixed. It's just a matter of which strategy we try first. That's really what we present as the randomization option. And I agree. I don't think either one is going to go out of business after the trial. It's not like we won't do any open or won't do any endo. I think we'll have to, as a specialty, those who treat peripheral vascular disease will finally have some high quality evidence in many of these challenging groups about what we should try first, as opposed to, as Dr. Pena alluded to, just endo first all the time. I don't know if, Tino, you want to comment?
Great. I'm going to urge all the audience members to please write down your questions. We're going to have some time for questions and answers in the subsequent panels as well.